Let me just say how hard it is to give someone else's lecture. And I found myself having to remind myself that, in fact, Ritu, this was not, she just prepared this a few minutes ago in the back of the room. So please join me in, again, thanking her for just a terrific effort for doing that. Next, I'm pleased to introduce Dr. Fiona Fennessy from Dana-Farber Cancer Institute and the Brigham and Women's Hospital, Harvard Medical School, who will be giving us the radiology perspective on the same topic.
Thank you, and thanks for the invitation to speak. So I'm a radiologist at the Brigham and the Dana-Farber, and for those of you who may not know the Brigham-Dana-Farber system, we're employed by both the Brigham and the Dana-Farber. We're paid by the Brigham, but we actually physically sit in the Dana-Farber reading the cancer imaging studies. But we're actually radiologists who were employed, and we're part of the Brigham radiology group. So I do have research support from the NIH, and I do consult on some cases from virtual scopics. So just to give a brief overview of what I'm going to talk about in these couple of minutes. I'm going to go through the mission of the imaging department at the Dana-Farber. I'm going to talk a little bit about the cancer imaging program, which I run. I've been running this since 2007, and it has changed an awful lot, particularly in the last 5 years. Peer learning for cancer imaging program fellows, or fellows who are training in cancer imaging. The challenges for the community radiologist, what we are trying to do to overcome those challenges, and then quality improvement approaches. How can we improve as cancer imaging specialists as a whole? So the Dana-Farber Cancer Institute, as I said, it sits right in the Longwood medical area, so it's right near Harvard Med School. It's right across the street from the Brigham. It's an outpatient facility, so we just see patients who come in, see their oncologist, get their treatment, but if they need any biopsy, if they need to be admitted, they're admitted through the Brigham. So we work sort of hand in hand, and there's a bridge connecting the two. So we don't do any biopsy work there. We do it all at the Brigham, but the patients are seen and treated at the Dana-Farber, and there's a group of 15 radiologists who sit at the Dana-Farber reading these studies. And the mission of the department is to inform individual management decisions, to promote as best we can successful and timely translation of discovery into clinical practice. So we do work with the phase 1 oncologists. And then one of our aims is to train the future generation of cancer imagers. So we have become very keenly aware of the fact that training in body imaging, or doing a chest fellowship, or doing a body abdominal and pelvic fellowship really is no longer training you to be a cancer imaging specialist. So why is there a need for the cancer imaging subspecialty training? So as I think has been said in the last panel, multidisciplinary precision medicine will require radiologists to consider the systemic nature and the genomic basis of cancer. So it's a systemic disease. It's not a disease just of the chest if the patient has lung cancer. It's not a disease of the abdomen and pelvis if the patient has liver cancer. It's a systemic disease, and we need to be able to consider the body as a whole and look at the body as a whole when we try to give a report. And then also we need to be able to use the language that the oncology and the pathology colleagues are using. And that's particularly more important now when we talk about the genomic basis. So when we go to when we sit and consult with our oncology colleagues, we want to sort of have an idea of what they're talking about. We don't want to just sit there and be totally unaware of what's going on. The complexity of the interpretation as radiologists has significantly increased. So it used to be that we would detect a tumor and stage it. We would find it, measure it, talk about lymph nodes, end of story, we're done. But now we're really have the ability in radiology to talk about tumor aggressiveness. And this is in terms of the Deauville with PET-CT, but also multiparametric MRI and functional CT. So instead of just characterizing it anatomically, we can actually measure the diffusion capabilities, which can translate back into how aggressive a tumor is. We can talk about the uptake of blood flow in the tumor. So is it very vascular? This will have an impact on the treatment types. And then looking at the newer therapies, we see changes within the tumor that may not necessarily be a reflection of tumor size, but in fact, it's just a reflection of how the tumor looks. So, for example, the GIST, the gastrointestinal stromal tumors, they respond to therapy, and then all of a sudden, this concept of a nodule within a lesion. So we begin to see, even though there's no change in size, we do begin to see a little area of soft tissue growing. So there's no change in the overall tumor, but we're able to detect these smaller areas. And again, diffusion-weighted imaging with MRI has been extremely helpful for us. We need to know the tumor response assessment criteria. So these have really changed a lot as well. It's not just RECIST, it's RECIST 1.2, it's the immune response criteria, the CHOI, etc. There's a whole bunch of them that we need to know, and many of us who work at the Dana-Farber read as part of the tumor imaging metrics core between Mass General and the Brigham, where we're involved in the clinical trials, and actually patients who are registered in clinical trials, we give an overall assessment based on these criteria. And then this is the key thing, I think, and the most challenging part for both trainees and for those who are reading cancer imaging studies, is to know the adverse events to the new molecular targeted therapies. So trying to keep up to date with these, and to know the potential adverse events is key, because sometimes we're the first people to actually know that there's a pneumonitis, to know that there's a problem within the lungs with some of these patients taking the new therapies, and we're able to warn the oncologist that there are changes in the lungs and maybe they should come off the therapy for a while and go on steroids, because this can be lethal. And then the rapid evolution in cancer biology, as we know it, and the availability of these therapies really have honed in on the fact that we do need to be cancer imaging specialists. So I just thought I'd throw up this image here just to show people. So for those of you who are not too familiar with, here we go. So to who are not too familiar with CT, so the top row here is pre-therapy. It's a patient. This person has colorectal cancer, and you can see these dark areas here. These holes are the tumors within the liver. So they underwent therapy with these drugs right here. And what actually happened was the tumors began to increase in size. So see these two here, they used to look like this. These three areas here used to look like this, and now they're definitely bigger. So you would call this progression potentially. But in fact, if you know the drugs that they're on and you know how they work, you can say, oh, well, it is increasing a little bit, but look how heterogeneous this was. This was a mix of soft tissue and a little bit of lower signal or lower attenuation, which usually means more necrosis. These tumors are becoming more necrotic. They're losing their solid component to it. And in fact, they're responding to therapy. So sometimes knowing the drugs that they're on and knowing what the initial picture in the time span, in a 3-month time span can look like is really important. And what we often say is that the distinction between liver and tumor, when this becomes really, really crisp, it actually may be a sign of response, even though it's increasing in size over time. So you can see that the distinction between the normal liver and the tumor, the black and white, if you like, is crisper. Then here it was a little bit more wishy-washy. And the reason it was probably a little bit less distinct and more heterogeneous is that the tumor is extending out, but we really don't see the margins that well, and now we do. So knowing these sort of criteria are really important. And so since 2007, we have really branched away from traditional organ type modeling for our fellowships. So when radiology fellows, or I should say residents, finish their traditional residency, they usually decide, I'm going to do bone, I'm going to do neuro, I'm going to do breast, I'm going to do chest, and they go into an organ-based fellowship. And that is, for the most part, accepted across the US, accepted across the world. Or potentially you can do a modality-based. So we do have ultrasound-based fellowships, and even more so MR-based fellowships. So MR-based fellowships were really, really sought after years ago. And when trainees would take that MR fellowship, they would do multiple different organs, but it was always just MRI. So for cancer imaging, though, we've moved away from that, and we've moved it towards a disease-centric model. So they do multiple body parts, multiple organs, and multiple modalities. So we have 8 fellows. We're not as big in Memorial Sloan Kettering, but this does not include neuro. These are just specifically from the chest down, if you like. So we have 4 positions for CT, MR, ultrasound, which we call our general tract, where they just read oncology cases, 2 in PET CT, 1 women's oncology fellowship, which we were just talking about, has become extremely attractive. We have a ton of applicants for this. So they do 50% breast and 50% general oncology. And this is through the Society for Breast Imaging, through the match. And then we do sometimes have a translational spot where fellows who have been with us for a year already and are really, really gung-ho in being an academic person in cancer imaging, and they really want, we try to allow them more research time. So if they have a project that they've been working on, because as a fellow, they do get 1 day a week research time, if they really have shown a remarkable ability to push the frontier back and be able to discover new work, we take them on as a translational fellow where they actually have more dedicated time, and then they can actually do PET-CT and a mix of whatever their interests may be. So what are the learning objectives for a cancer imaging fellow? So first off, they need to be familiar with the genomic classification of tumor type. So it's not just your standard old type of classifying tumors. The genomic classification, as we now know it, they have to become very familiar with this. They need to know the standard chemotherapy and the molecular and targeted immune therapies, and we have a lecture series devoted to that. They need to be familiar with both the anatomical response criteria where you get a decrease in size, such as with RECIST 1.1, and the functional criteria where we're not just measuring size anymore. They need to be familiar with the drug toxicity and be able to know when to start to call an oncologist and say, I'm a little bit worried here about toxicity, any oncological emergencies. And then being familiar with the template reports. This is becoming more and more important because the oncologists that we work with like a summarized report of the body. So sometimes we'll do chest, abdomen, pelvis, and bones if it's, and lower limbs if it's melanoma. And they like to kind of know what the summary is. How is this patient doing? It's not just the chest is doing this and the abdomen is doing this. They want a templated report and what's the impression plan? What's the work? What's next in line for the oncologist to do here? And then understanding the role of the oncologist in the early phase clinical trials, because we do play a big role in the early phase clinical trials. There's a lot of discussion if the patient should come off, if they should not come off, if they're, it's all very early drug discovery. And it's really important for the radiology group as a whole to be there from the beginning to sort of inform decision making and to be part of the program. And I think once we're there from the beginning, I think the drug companies then begin to realize that they need to include imaging in the drug trials that they're doing to look for assessments, that they're not just doing CT scans. And then to realize their importance, right, to learn how impactful imaging is on actual patient management. So this is just an example here of a case here on the left. This is a person with melanoma. Oops, sorry, go back, go forward. This is a case with melanoma, and you can see this is a straightforward case. There's a mass right here, and with therapy it decreased, and then there's a little node here in the lung, and that decreased. So if the body people were reading this, they would say a response. If the chest people were reading this, they would say it's a response, and it's all great. Everybody's in agreement. But what happens sometimes, so for example, if you see this patient here, he has or she has melanoma, and she's responding where she has had the sites, but all of a sudden she's got all of this diffuse uptake in the chest. So she's probably got a sarcoidosis-like reaction, but you can see that the chest people may have a difference in response, a different report to what the abdominal people are reporting. So looking at the whole picture is something that cancer imaging specialists do very well. So what is our training like for the fellows that we have? So it's a very comprehensive disease-focused curriculum. It meets the trainee learning objectives, and really as a faculty member it keeps us up to date. We do sometimes change the people we have giving lectures, but the basic lecturers, we have them come back every year, and the faculty really enjoy them as well. So in July we have an introductory lecture series to sort of get their feet wet. It's modality based, so we talk about specifically what you need to know in ultrasound for as a cancer imaging fellow, what do you need to know in MRI, and it's a clinical overview. And in the first week, so this is just as an example here, Jeff Shapiro, who runs the Early Drug Development Center, this was July 2016, but even in July, we have him come And he comes every single year and gives the big picture on development and drug therapy and targeted therapies. And he goes through, these are his just two of his slides here. So you can see that right from July, we're kind of letting them know these are the kind of things that you guys absolutely need to know. And then from August to June, what we do is we do disease-centric blocks. So we focus a block on lung, a block on GI, a block on GU, etc. And we have talks by radiologists in the field, usually local in Boston. So someone from MGH may come over, someone from the Brigham will come over. We have our own specialists at the Dana-Farber, and then we invite the oncologists to come down and sort of give us the latest and greatest of what's happening. And so every week, our coordinator, Erin, sends, so this was an email sent to me in January, and so she'll tell us, it's sent to all the staff and it's sent to all the fellows and it's sent to a lot of people in the Brigham as well. It's letting know who's doing the teaching, who's doing journal club. As you can see here, this is the seminar details, and you can see this is the seminar. It happens every Wednesday, and on this certain day we had Anne Case talk about update on aggressive lymphoma. So we all know what's happening with aggressive lymphoma. What are the drugs that are taking place? What are the improvements that have been made? What's been FDA approved, so that we know where we stand and we're up to date with that. And then we have our fellows actually run the drug conference. So we give them a certain type of therapy that they need to know the bones about. And then they, for like just 15 minutes in the reading room, can tell us what this drug is used for, what type of tumors respond to it, what's the molecular basis of it, and what are the side effects that we need to know about. So we do that every single week. And then this is the following week. You can see here that this changed somewhat, but we send it to 131 people. So we do invite people from the Brigham, the fellows at the Brigham in different sections, if they're free, that they can come over. We do receive the med school, Harvard Med School does give us CMEs for this. So we did manage to get CME approval for this. So even faculty can come over if it's in their area of interest. And follow up with what we're presenting. So it is quite complex. A lot of the cases, we recently had somebody from abdomen come over, and he was there for the aggressive lymphoma one, and he said he understood 5% of what they were talking about. I think we would probably understand 40% of what they're talking about. So we're a little bit better, but it is quite complex, what we're trying to teach. So we've published a couple of papers on how we have managed to change our fellowship and how it really is tailored towards precision medicine in cancer imaging. So if any of you want to take a look at them, they're from the American College of Radiology Journal. So where have all our fellows gone? So let's just look at the past 3 years, 24 graduates. 50% have gone on to faculty appointments, and importantly, 50% are in private practice or in the community setting. And that, I think, talks back to what we talked about in the last session, was how do these people then keep up to date? So they are, as they leave, they are mindful of the effort to keep abreast of constantly evolving knowledge in cancer biology. So just to point to two of David Larson's papers here, how do we keep up with this peer learning? And how do they in the community keep up with peer learning? Because we all know it's extremely important. So as in Memorial Sloan Kettering, we do have a Dana-Farber consultation service, which is extremely important for those of us who actually sit there in terms of peer learning. So we're part of a multidisciplinary team. We're embedded in the clinic. So we're in the GU clinic, GI clinic, and we interpret cases for in-house and outside studies for live patients. So this really allows for the open dialogue with the clinical team and for the QA of the peer read. So we sort of get a better idea from the clinical team of what's happening, and then we can easily call downstairs to the person reading the case and say, so I got a bit more information on this case, you may need to change your read somewhat, because what you're getting downstairs is just whatever is in Epic. So it does change around a little bit. So there is a lot of phone calling back and forth, and the opposite occurs as well, where somebody who's actually physically reading the case will say, oh, there's a small PE here, let me make sure the person upstairs who's dealing with the oncologist actually can see it, and will relay that information. And then importantly, this takes all the phone calls out of the reading room. So the people who are in the reading room reading the cases can actually just focus on doing so. So Ramin Khorsani and his group at the SEBI, whatever, however, I'm not sure how he pronounces it, have introduced this anchor, this alert notification of critical results, which was to inform the clinical people to facilitate notification. So when we have a critical finding, it's documented, the time it's documented, and then there's feedback that they say, okay, I have this, I understand this, and they have to physically go in and do this. But more recently, Ramin introduced this worth another look, this wall, this purple anchors, which was designed to promote, enhance, and encourage peer learning amongst the radiologists at the Brigham and the Dana-Farber. And it really is just for peer review purposes between us. And I have to say, as a user of this, when we started this first, I think a lot of us were very anxious about it. Is it going to be finger pointing? Oh, you guys missed this. You're not a cancer imaging specialist, and you missed this sort of thing. And then there would be a lot of, unhappiness between people. But I think what Giles has done, Giles Boland, our chairman, and Ramin have done is that they've made sure that we send so many of them that actually you get over that fear pretty quickly. And then we begin to realize that it's actually extremely helpful to each other in terms of follow-up and in terms of just asking questions. So what happens is you get it. So this is... somebody would have sent this to me, so you get this in your inbox, in your email, and it just says you have worth another look here. You need to go in and see what it's about. So once you get this email, there's a little squeeze of the adrenals because you're not sure if it's a miss or if it's a good call. So you can send these worth another looks for good calls as well. So just to give you examples of more recent ones that I've had. So this was a follow-up that Pam DePiro sent me. Said she would have read the follow-up, and she said, or she was in the consult, and somebody came back and said, oh, this guy had a cardiac echo, and this is the finding. So yes, good job. You found this on the CT. This is a little bit of feedback, and then you confirm that you've actually understood and that you've closed the trail on this. Another one, I sent this recently to a fellow of ours. It was a patient with smoldering multiple myeloma who had a thigh mass. And it sort of didn't quite fit the picture, the clinical picture of extramedullary myeloma. So we were a little bit concerned. It was a solid mass. It was enhancing. The patient then had an MRI and a biopsy, and it would turn out to be a sarcoma. So I can give the fellow some feedback on this. And it just saves keeping all these files of cases that you have to look for feedback on. This was a case that I read the MRI on a patient on, and I thought I saw a right medial femoral head lesion, but on the bone scan that the person downstairs got on the same day, they didn't call it. When I windowed it, I thought I could see it, and then Chris Sakelis, who works in PET-CT, will answer me back, and he'll say, oh, there might be some faint uptake. So it just allows for feedback. We teach each other the findings in the different modalities, and we're able to catch, basically, it's almost like a double read. We're able to catch things and give each other some feedback. So I think, and Ramin, you can talk to Ramin about these purple alerts, but I think it's working extremely well, and I think all of the intrepidation about it is gone. So what happens, that's fine if you're in an academic centre, but if you're in the community, what happens? It's obviously extremely challenging to keep up to date with all the new information. We can barely keep up as it is. So all these new clinical trials, all these new drug discoveries, it's extremely challenging. It's also, I think, difficult to kind of summarize something into a very succinct report that you want the oncologist to, or you feel the oncologist needs to know to act upon. We're very used to, I think, in the community in focusing on one type of study and not looking at the bigger picture. And we also do not have the clinical information, which is crucial. We don't have that feedback from the oncologist. I think speaking to some fellows who've gone into the community, they really get very little clinical information to start with. So they're sort of behind the ball before they even start. So it's really, really difficult for them. So I think I would be interested in knowing what possible solutions people have. I know that those of ours who've gone out into the community, they have the ability, if they want to, dial into our seminars via WebEx and sort of at least have an hour a week where they can get CMEs and they can keep up to date with what's happening at the Dana-Farber. And then we do, through the Community Radiology Division, part of Brigham and Dana-Farber, they are part of our Worth Another Look system. But having said that, I do have to say that we recently, for example, at the Dana-Farber, we have taken over Foxborough, reading any of the Foxborough oncology cases. So they're not so familiar, or they're not so comfortable reading these cases, that we now have taken them over, and our oncologists prefer that. So how to improve the training and performance in the future? So I think, which we spoke about as well, is correlation with digitized pathology or the genomic maps is going to be crucial, because as a radiologist, we really can have, to some extent, we can try and define what's aggressive versus non-aggressive, but being able to correlate with pathology and figure out what we can learn of our imaging is really, really important. Active growth versus no growth, and response versus no response. So as an example, I do a lot of prostate cancer research, and I just wanted to show you this example here of how crucial correlating with pathology is. So these three images here are MRIs, and it's a little tricky on the T2, but maybe we can, for those of you who are not radiologists, if you want to look, this blurry thing here is the prostate, and this dark area here is on diffusion. It's a black area, so it's very likely to be cancer. And then K-trans is a sort of a measure of enhancement, if you like. This is on the K-trans. There's a hot area here, so you're like, oh, great. There's actually two areas which light up, and they correspond to the whole man pathology. And I should point out that to even do whole man pathology on a prostatectomy specimen is no easy task. We did this on a couple of maybe 30 cases just for correlation, but this was a pretty arduous task to ask our pathologists to do at the Brigham. But interestingly enough, what we did find was, if you look here, it looks like the more posterior part was picked up on the K-trans, and the more anterior part was picked up on the diffusion. And when you look at this, actually, there was a distinction. One was Gleason 7 and one was Gleason 8. So for some reason, different parts of our sequences with our multiparametric MRI are picking up different characteristics in the tumor. So the only way we'll ever really know how good our maps are is with really, really good pathological correlation, which requires it to be digitized and registered, which of course will be down the line. This was just another example of how we really, really rely on pathology to educate ourselves as radiologists. So again, this is a prostate case, and for those of you who don't read it, this bright area out here is where you get 70% of the cancers. This dark area is the tumor. This dark area is the tumor, and then this is the enhancement. So it gets a lot of blood. It's bright. And then anyone can see, I think, on the gross pathology specimen that something looks different here, let's just put it that way, and that this correlated quite nicely with tumor. And this was a Gleason 3+4, which was a clinically significant tumor. Not really, really high on the aggressive scale, but it was a clinically significant tumor. And if you compare it, though, to this case here, where we really could not see tumor very much here at all, it's just kind of wishy-washy, heterogeneous. It's not really bright, it's not really dark, and nothing jumped out on diffusion. But the pathologist, when she looked at it, she marked that there was an area of tumor here, an area of tumor here. And what we did was we sat with her and marked out the percentage of normal and percentage of tumor. And what had happened was that in this, it was like 80-90% tumor, very little normal. Here, it was like 30% tumor, 70% normal. So it was really growing into normal tissue. But the problem here was this was a more aggressive tumor, and we missed it. So this was a 4+3 with elements of a Gleason 5 pattern, so a more aggressive tumor that we really could not see with radiology. So I think this digitized correlation and registration with pathology and imaging is going to be really, really key to figure out what we're missing in radiology and how we can improve upon that. And sort of extending from that, then of course, is just talking about genomic evaluation, which tumors or where there's amplification in tumors. So we're trying to do a very nice little project again with those 30 cases. We're going to town with the 30 cases that we've home pathology on, but we're trying to do biopsies of them and seeing, with the areas of restricted diffusion, can we actually talk about some heterogeneity within that are associated with gene amplification. And we're getting some nice results where it looks like if it's a very homogeneous tumor in MRI, all the tumors within that patient have the same genetic pattern. If it's a very heterogeneous tumor, there's different gene amplifications. So this will all, of course, point towards the tumor heterogeneity index. But I think going forward, this is the sort of thing that we need to teach our fellows. And I think in maybe 10 years, we'll be all integrated and we'll have something digitized and be able to actually do this, teach pathology, teach genomic evaluation, which will really, really help us figure out what we're missing and what we can learn from our MRI images. So in summary, imaging is an increasingly integral component of cancer care. However, given the rapid evolution of the cancer biology knowledge and now all the novel targeted therapies, the complexity of radiology interpretation has increased, and it really necessitates cancer imaging expertise and training, which is what I think Hetty had mentioned in her talk this morning. A rich, dedicated curriculum for training cancer imaging specialists will provide fellows with the knowledge necessary to be an integral part of a multidisciplinary team. So I think this is really crucial. We're not just a service team, we're really part of this multidisciplinary team. However, we do need continued education and ongoing feedback, both from our peer radiologists with our Purple Alert system, but also from the clinical colleagues where we right, where we wrong. And this will be necessary to remain up to date in such a dynamic field. Thank you.